Hey, this is David Pope from Clinical Edge at clinicaledge.co, and in our research review, today we're going to be having a chat about the utility of clinical tests to diagnose MRI-confirmed gluteal tendinopathy. We're looking at patients presenting with lateral hip pain, and this is a study performed by Grimaldi et al. And released online in 2016. So the purpose of the study was to determine the diagnostic utility of clinical tests for gluteal tendinopathy relative to MRI. So they had 65 participants with lateral hip pain that they recruited in Brisbane and Melbourne. They had to be 35 to 70 years old with lateral hip pain of greater than 4 out of 10 on most days within at least the past 3 months. So this is your normal lateral hip pain patient that's coming in, so really good study group. And when you look at the exclusion criteria, it still fits in with your normal lateral hip pain patients that'll be coming in. So they excluded participants that had a corticosteroid injection in the hip region in the past 12 months, if they'd had any hip or lower back surgery, or no neurological disorders, or any other relevant medical conditions like fibromyalgia. Or if they had any contraindications to MRI, because as you see later, they're going to be comparing their results to MRI, and that included things like cardiac pacemaker or metal implants. So here's the test that they performed. We're going to go through the tests first, and then talk about their accuracy, and then how you can go about using these in your clinical practice. So first off, they considered a positive when you had more than 2 out of 10 and of pain in that patient, and it was the patient's pain that they presented with. And it was over that greater trochanter. So first off, they got the hip fader. So you can see that in the picture. Hip flexion, adduction, external rotation. And then they added in a resisted component to it for the second test. So resisted internal rotation while they're at end of range external rotation. So that increased those tensile and compressive loading of the gluteal tendons on that greater trochanter and in that position. So then we move on to the third test, which is the hip faber. So we're looking at hip flexion, abduction, external rotation. So they put that lateral malleolus over the patella of the contralateral leg and lowered the knee. So they end up in that figure 4 position. The fourth test is hip adduction in side lying. So you can see it there. They've got the leg in line with the body, and then they drop it down to end of range adduction while maintaining the pelvis perpendicular to the bed. They then perform some overpressure on that and check for pain reproduction. So the fifth test was the same test, but then they added isometric abduction at end range adduction. So they resisted at the knee while a patient pushed directly up, and so that added that active tension component of your glute med and glute min tendons. Sixth test was your single leg stance. They had to stand on one leg for 30 seconds, and they could use their fingertips on the wall for balance. It wasn't a balance test, and it was a positive if they got pain within 30 seconds of performing the test. So the final test was palpation. So they got them in side lying with that hip that was symptomatic uppermost. They flexed their hips to about 60 with knees together, and then they palpated systematically around that greater trochanter like they did in Falvey et al. So the positive test was pain with palpation of the glute med or glute min tendon insertions. They then had MRI within 2 weeks of the clinical examination. They compared the results. So in MRI, 77% of the MRI reports identified the presence of gluteal tendinopathy. So if we look through which of the tests were the most specific, so a specific test is more helpful for making a diagnosis more likely or ruling in a diagnosis. So the most specific test was your single leg stance, and that had 100% specificity, but it was pretty poor at ruling things out. So if you test positive, you've got a really high likelihood that your gluteal tendon or tendinopathy is present on MRI. Our other specific tests were your fader and your adduction tests. They had high specificity and high positive predictive value, but when they added the resisted muscle contraction to each one, the diagnostic accuracy and the sensitivity, specificity, and your predictive values of both tests got better. So that's our specific tests. Our sensitive tests are really helpful for helping to make a diagnosis less likely. So if you've got positive results in your specific tests, you also want to try and get and check that your diagnosis is correct with a sensitive test. So try and rule it out. Prove yourself wrong. So we've got palpation over the greater trochanter, and that one had the highest sensitivity of 80%, but had a really low specificity at 46%. So what that tells you, that a lot of people are tender when you poke around their greater trochanter, but if they are not tender, then that helps you to eliminate or make it less likely that the person has a gluteal tendinopathy. So you want that combination. You want that combination of your tests with your higher specificity to help to rule it in, and your sensitivity, you want that to be painful as well to help you rule it in. So how can you use these results? So when we're diagnosing gluteal tendinopathy, as it's observed on MRI in populations presenting with lateral hip pain, you combine that your palpation with its high sensitivity and your accuracy with any of your other individual clinical examination tests with higher specificity, and that'll help you identify your patients that have gluteal tendinopathy on MRI. And with your tests, you can add resistance to help improve your specificity. So it's always important to remember with MRI that we can't correlate it with a symptomatic presentation. You're going to detect more tendinopathies on MRI than you're going to detect with your clinical examination. And in Blankenbaker et al. In 2008, they found that all of the patients with trochanteric pain and 88% of people without trochanteric pain had these peritrochanteric abnormalities on MRI. So that's a really good statistic to remember, that just because you found it on MRI, you've identified pathology, it doesn't mean that's your symptomatic or source of your patient's symptoms. So to sum it all up, if you're assessing patients that have lateral hip pain, you want to use a combination of your most specific tests that involve compression and active tension, like your single leg stance, resisted fader, and resisted adduction, and your most sensitive test, your palpation, and that'll give you your best diagnosis. So if they're not tender on palpation over the greater trochanter, you're really looking at something else besides gluteal tendinopathy, and you want to consider some other pathologies in that differential diagnosis. So thanks for joining me for this research article today. Remember, if you've caught us anywhere else besides on our website, head on over to clinicaledge.co and check out all the videos, webinars, podcasts, and other resources we've got for you there. And I look forward to seeing you on the website.